starting time you're ready to get their attention.
Hey guys, can everybody hear me? All right, okay. So my name is Talha Malik, and probably most of you guys don't know me. I'm a Crohn's and colitis specialist at UAB. And I got an email several months ago to come and do a talk on IBD. And because I kind of see a lot of Crohn's patients, and I thought that's kind of more relevant to at least my practice, and I felt this may be relevant to many of you guys too. It's kind of 56 slides that I'm going to go through. I'll try to make it fun. I know that I'm talking to an internal medicine audience, so I'll try to maybe not go over details of clinical trials and stuff, but I just will send off, maybe give you guys pearls and main messages from what I want to do. For example, I treat chronic disease, Crohn's, and many of you guys know what a chronic disease is. It kind of, stays with you. So you have to have a systematic, standardized plan or management plan to treat these patients. So in terms of Crohn's, and this may be relevant to all other diseases that are chronic as well, but I like to have a systematic, standardized, kind of stepwise plan or management strategy. And my first step in treating Crohn's is to classify disease. The best analogy that I can give to you guys about classifying disease in Crohn's is to know what the anatomy of that disease is. For example, in many cases for lay audience, saying somebody has Crohn's is enough. But if you are going to treat Crohn's or send referrals to another doctor or GI doctor with Crohn's, you need to be able to describe the anatomy and know the anatomy of the Crohn's of the Crohn's type. For example, is the Crohn's affecting the small bowel? Is it the large bowel? Is it penetrating type? Is it going to cause a perforation? Is it going to cause just ulcers that you have to deal with? Is it going to cause perianal disease? So before we go any further, we need to know exactly what is the anatomy of Crohn's that our patient has. That's step one. Step two is, again, not a great analogy, but you need to know the physiology or the pathophysiology of Crohn's. For example, how active is this Crohn's? Is the person that we're seeing with Crohn's, is that person in remission? Does that patient have mildly active disease? Does the patient have severe fulminant Crohn's? The reason I say that we need to know the anatomy and the physiology or know the class and the category of disease activity, because that will drive what we will do for the patient in terms of medications or management. So once we have somebody in our clinic and we know what type of Crohn's they have in terms of where the Crohn's occurs and how active that Crohn's is, the next step is we need to identify a management goal. Now, about 10 or 15 years ago, when I began training in GI, specifically in Crohn's and colitis medicine, my senior colleagues used to say, if somebody comes to you and has a diagnosis of Crohn's, and I'll talk about the classification in a minute, and says to you, hey doc, I feel great. What you do is, okay, he feels great, he's obviously in clinical remission, send him back home and tell him to call you when he gets sick or she gets sick. That's not the case anymore, because we know among GI doctors that anytime somebody feels well, that person or that patient's condition does not necessarily correlate with what's going on inside. So we're heading towards an era of endoscopic treatment or deep remission. So what drives patients with Crohn's prognosis is not how they feel. It's what you find on endoscopy, on a radiological imaging study, and that's just kind of the key message I want to get through. That is why you identify management goal, which used to be achieve clinical remission, clinical response, but now, more so than that, it is to achieve endoscopic remission or endoscopic response. And similarly, other stuff that you can add in there, for example, reducing hospitalization rates, reducing steroid dependence, reducing, decreasing the chance of them dying from Crohn's, which doesn't happen a lot, but can. And then once you know the class of disease, you know how active this disease is, and you've identified your management goal, which for me is usually endoscopic response. The fourth thing that you want to do, or the fourth step that you want to take, is select treatment agent. And how do we select treatment agent? So I'm actually working on, hopefully one day, getting an app which will disperse to everybody, where one could actually have all these 5 steps on an app. So somebody sees a patient with Crohn's, they can fill in each step of the app, and the 4th step, when they click 4th step, for example, you put in, this patient comes in with Crohn's affecting the ileum, and the colon with perianal disease. He's having 6 bowel movements a day, significant joint pains, perianal disease, enteroduodenal inflammation. Therefore, he has moderate to severe disease. Click that in. Step 3, I wanna put him in endoscopic remission. I want to heal his mucosa. I want to heal his colon, not just make him feel better in terms of, I feel better so I can go home, but I want to go in and make sure his mucosa is also healed. And step 4, give me the best treatment agent. So what this app hopefully will do, and what I'll talk about in a minute here, is it draws all the clinical trial data for patients with that type of Crohn's, with that activity and with that as a goal, and then gives you the treatment agent that is the most, that has the most evidence backing its use. And I'll talk a little bit about that today. The 5th step, which I'll not talk about a lot, but I want everybody to know, and I guess it's an internal medicine audience, it's kind of relevant to you guys as well, is to maintain overall health and prevent complications. What do I mean with that? By that, what I mean is, for example, a patient comes in to see me in the Crohn's and colitis clinic at UAB and says, oh, I'm very sick, I have abdominal pain, diarrhea, family history of Crohn's. I take him to the endoscopy suite and I scope him and I find that he has ileal ulcers. And on biopsies, there's chronic inflammation. So I diagnose him with Crohn's ileitis, Crohn's ileitis, and there's like several ulcers, 7 or 8 ulcers with significantly inflamed mucosa between those ulcers. So he has a moderate to severe endoscopic disease. I put him on a biologic, let's say a TNF blocker, and then I bring him back in about, let's say 3 to 6 months. He comes back and says, okay, I'm ready to come back, tell me how I'm feeling. I take him to the endoscopy suite, I scope him, and all the ulcers are gone. And I tell him, wow, the biologic worked. You have achieved endoscopic healing. That's what we're trying to achieve so that you can do well in the future. Go home, I'll see you back in 6 months. And he says, doctor, you haven't really helped me. And I ask him why. Well, because since you put me on this biologic, I've had 1 pneumonia in the last 1 month. I always carry a sore throat. I have headaches all the time. I can't sleep anymore. So have we really helped him? So again, a lot of IBD doctors, perhaps some medicine doctors, sometimes they go for objective findings, and we say, well, we see no ulcers in your belly anymore, don't bother us. But the thing is, you have to maintain overall health. You need to make sure they get vaccinations that they need, and you need to prevent complications that occur because of what you've done for them. So I say in Crohn's treatment, and I'm hoping that I can sell this to everybody else who treats Crohn's, and GI doctors, and everybody else who cares about patients, that our job is not done when we just kind of heal the ulcer or heal a problem. We need to kind of watch that patient and maintain his overall health and bring about not just physical, but emotional and psychological and overall well-being has to also be kind of driven after. So these are the 5 steps and all of this talk that I'm going to do in the next 35, 40 minutes is going to kind of revolve around this. And I'll try to make it very relevant and as much fun as possible. So how do we classify disease? So anybody who sees a patient with Crohn's needs to know that Crohn's is not just a very homogeneous, very kind of single streak diagnosis. It's a heterogeneous disease which can occur in many manifestations. It can occur in many ways. For example, based on age of onset, we classify Crohn's into pediatric onset, early adult onset, and late adult onset. Location, also depending on where the Crohn's affects the patient. It's mainly intestinal, but it can also have systemic effects. So you have ileal Crohn's, colonic Crohn's, ileocolonic, and then you can have enteroduodenal Crohn's as well. Behavior, you can have inflammatory Crohn's, which is just ulcers. Then you can have stricturing Crohn's where there's narrowing. And then you can have penetrating Crohn's where you get fistulas or perforations. And then you have modification to that. So what do we need to know in terms of age of onset? And I'll just do some single liners to explain why we need to know whether it's pediatric onset, early adult onset, or late adult onset. There's other reasons for that, but I want to try to make it simple and just try to say things that everybody can remember easily. So the pediatric onset Crohn's is Crohn's that occurs or begins in someone less than age 17 years of age. This Crohn's is the most insidious type of Crohn's in which they may but may not present with florid diarrhea, abdominal pain, they might just say to us, oh, or their parents, their mom and dad might come in and say, oh, you know what, our kid has been it's not been getting taller. He's not been growing in weight. He seems anemic. He seems weak. So this is the most insidious form of Crohn's, where you have to have a high suspicion. Early adult onset Crohn's occurs when it begins between the ages of 17 and 40. This is the most virulent, or perhaps the most intense or most severe form of Crohn's, the most bombastic type of Crohn's, where they come in, but it's also idiopathic. You can't identify that trigger. They may have some risk factors, but you have to have a low threshold to suspect this. They come in with severe symptoms, but usually you can't identify or pinpoint a trigger that caused these symptoms. Then, and this is the most severe form of Crohn's, and this is what affects most of our patients. Then there's a late adult onset Crohn's, which occurs in older, relatively older patients, which occurs after 40 years of age. This Crohn's is generally the mildest form of Crohn's, not always, but generally. It also is not usually idiopathic, where you hear about a history of tobacco use for many years. You hear about somebody going and having a pizza somewhere, traveling overseas, and coming back with a virus that they call a virus, and never getting better, or just not getting better for months. This is how the late onset Crohn's occurs or begins. And you can usually identify, not always, but you can usually identify a trigger to it. And it's the easiest to treat when you compare how treatment of Crohn's patients goes. Now we know what the age of onset is. What about location? So location-wise, Crohn's can occur in the ileum. It can occur in just the colon. It can occur ileum, the distal ileum, and the proximal colon. And it can also occur, mostly if it occurs, isolated in the upper GI tract, and mostly antrum and duodenum. So if you see somebody with Crohn's, all patients with Crohn's, 1/3 of them will have ileal disease, 1/3 of them will have colonic disease, 1/3 of them will have ileocolonic disease, but 5% will have isolated upper GI disease, just the antrum and duodenum in most cases. Why do we really need to know exactly why one has one versus the other? Because if somebody has ileal Crohn's, it's extremely unlikely that they will ever have colonic disease. If somebody has colonic disease, it's extremely unlikely that they will have ileum. For example, if somebody with Crohn's has colitis, and he says after many medications that, you know what, I'm done with medication, I want to get surgery, I want to be done with this thing. Yes, you can say confidently that yes, if we do a colon colectomy and give you an end ileostomy, it's unlikely. It can, about 10 or 15% still have recurrence, but 85 to 90% of patients will not develop ileal disease if they purely had colonic disease. So we need to know this, because then our treatment plan will be driven by what the location of this Crohn's is. And then there is a small u, which means upper GI disease modification, which suggests that if somebody has colonic, ileal, or ileocolonic disease, they can still have antroduodenal inflammation, and 4% of all patients with Crohn's will have severe antroduodenal inflammation diagnosed with just chronic inflammation on biopsies. And the treatment is you just add a PPI to a biologic that works for their other location. Okay, so now we know the age of onset, we know the location, and now we're going to talk about the behaviors. So non-stricturing, non-penetrating disease is where you just see ulcers and inflammation. They don't perforate, they don't obstruct. B2 or type 2 is where they get stricturing, in which they're inclined to, or can, if you don't treat them aggressively, can obstruct. The third type is penetrating, where they can either develop fistulas, perianal disease, or with or without perianal disease, and they can also perforate out of nowhere. Now, 80% of people who begin with non-stricturing, non-penetrating disease at 20 years will get penetrating complications if you don't treat them aggressively as soon as possible. So so unlike the location, behavior changes unless we get to them early on. So we need to know, because the most aggressive form is penetrating, slightly less stricturing, slightly less inflammatory, and they actually this is like a progressive course, depending on how aggressive you are and how good you are at treating these patients at various stages. Then there's a perianal disease modifier. So of all patients who have colonic or ileal or ileocolonic disease, about 30 to 40% will have some perianal manifestation, like an abscess, a fistula, a large hemorrhoid, a stricture, There is a small percentage of Crohn's patients who will come with just isolated perianal disease, and that's about 3 to 5% depending on which data you look at. So now we kind of know most of what we need to know about classifying disease. So when somebody refers a patient to a IBD clinic, and this seems overwhelming a little bit, but all this is 3 or 4 slides. So I urge everybody who's going to refer patients to GI to get the language right, because this will actually help me when I see them in my clinic or somebody else to get going right away. We know exactly what we need to do. I will mention a few more things. 40% of people with Crohn's, with patients with Crohn's, will have extra-intestinal manifestations. Crohn's is primarily an intestinal disease, but it's truly a systemic disease. That's why almost half of them will have other symptoms. For example, joint symptoms. There's 2 types of joint symptoms that you'll see with Crohn's patients. And I'm telling you this because I kind of feel that your suspicion will be higher if you have somebody with diarrhea, abdominal pain, possible family history, who also begins to complain of joint pains that seem inflammatory. So what are the 2 types of joint pains that occur with Crohn's patients? Axial arthropathy and peripheral arthropathy. Axial arthropathy can occur as a sacroiliitis, pain here in the hip, or ankylosing spondylitis, which is pain right in the middle. Then type 2 can occur in 2 ways: peripheral type 1 or peripheral type 2. Type 1 is which occurs in peripheral big joints, hips, knees, shoulder, mainly hips. The key to remember in this case is that if you treat Crohn's in the intestinal tract, the hip pain will respond. Peripheral type 1 arthropathy actually is the only arthropathy which actually parallels disease activity. If you fix their intestinal inflammation, very likely their joint pains will also get better. Peripheral type 2 arthropathy is arthropathy which occurs in the small joints, mainly your hands. The key to this is this does not parallel disease activity. It can occur with Crohn's, but it doesn't parallel. And the key traditional immune modulator that you can use to treat patients with type 2 peripheral arthropathy that complicates Crohn's is methotrexate. Remember the keyword methotrexate for type 2 peripheral arthropathy, because it's a very useful drug to add to a biologic that you may be using to treat Crohn's patients. And then, you can have erythema nodosum. These are like painful red nodules or bumps in one's shin or one's shin or thigh. And the key to remember this is it's always self-limited and almost always parallels disease activity. So if somebody has erythema nodosum, has Crohn's, they call you, hey doctor, I see Malik at the IBD clinic at Kirkland, but I'm getting these painful red spots. And do I need to go to him for this? You can say, yeah, but this is going to parallel disease activity. It means that your disease is probably active, so we need to modify therapy and try something which can help your disease so we can help this get better too. But you can use some topical therapy, but it does get better if you treat the intestinal Crohn's. Pyoderma gangrenosum is when you have these wound-like lesions in the belly, in other places, with huge pathology. So if you touch them or try to manipulate them, they kind of get worse. This does not parallel disease activity, but in response to topical therapy, oral steroid therapy, and also biologics. And then you can have episcleritis and aphthous ulcerations. So we've done we've talked about the anatomy of Crohn's. So Crohn's is classified first. So we need to know what is the age of onset, what is the location of Crohn's, what is the behavior of Crohn's, what type of Crohn's does this patient have, and then are there any extra-intestinal manifestations. Once that is done, you put that in your chart, and I know exactly what I need to do when I see that patient. Okay, next thing, step 2 is categorizing disease activity. Now we know the anatomy of the disease. We know how the disease is located, or where is it located. Now I need to know how active is this disease. I'll just talk about clinical disease and endoscopic disease. Clinical because it's relevant to everybody who's a clinician. Endoscopic is relevant to those who are GIs here. I don't see any GI here, but I'll talk about it anyway. So there's 3 clinical disease activity scores. There's one called CDAI. And I can tell you, those who are going to take the board anytime soon, some of this stuff shows up on the board, because I remember getting some of this stuff on internal medicine boards. So clinical disease activity score, you can use 3 major scores. CDAI, Crohn's Disease Activity Index. It's a painful score. I recommend nobody use it, because it takes about a week to calculate. and the physician fills some stuff out, the patient fills some stuff out. It's validated, but it's just not practical to do it unless you're in a research setting with a lot of time where you just see 5 or 6 patients in a day. There is a summarized version of a Crohn's disease activity index called the Harvey-Bradshaw index. Who uses MedCalcs? You guys use MedCalcs? So when somebody wants to do, you get some formulas, there's an app called MedCalcs, which can give you the AA gradient, the anion gap, you just put in those numbers. So Harvey-Bradshaw index is in MedCalcs. I think the paid version, which is still not that expensive though, but it's in there. So Harvey-Bradshaw index is a summarized version of the CDAI. All it looks at is how many times is the patient having to go and have a soft to loose bowel movement, how much abdominal pain are they having, how bad they feel, and all about extra-intestinal manifestation. Do they have hemorrhoids? Do they have stricture? Do they have a fistula? Are they complaining of joint pains, eye pain, mouth ulcers, stuff like that? You quickly, it takes about 2 or 3 minutes to do it when you have MedCalcs. Those who see these patients a lot can do it because it's pretty easy to remember too. The reason I say we should be doing it because in this country we need to standardize care where what you see, either you take pictures and show it to me or you do calculations so I know exactly what you were calling moderate disease, what you meant when you said somebody has mild disease, what you meant when you said somebody has severe fulminant disease. If we all get into a habit of standardizing our care across hospitals, across healthcare systems, I think we can provide better care to our patients. However, a GI clinic will probably have the time to do this. There's another eyeball test that we all hear about and talk about. There's an eyeball test that ACG, Crohn's disease, ACG came out with, in which if you see one of your Crohn's patients who can't get into the IBD clinic or the GI clinic, you can even eyeball that person with Crohn's that happens to be under your care, and you can have a good idea about where they are in terms of Crohn's disease activity. What is that eyeball test? Somebody with Crohn's that you see for, let's say, blood pressure, hypertension, comes into your clinic and you ask them, hey, how are you feeling? And he or she says, I feel great. Are you having diarrhea or abdominal pain? No, I feel great. I'm on this biologic and I'm feeling great. You don't need to calculate anything. You can just say this patient is in clinical remission. This patient is in remission. And that usually correlates with a CDAI, which takes a week to calculate to less than 150. And then what about mild to moderate disease? So what about somebody who has mildly active disease? Somebody who's easily ambulating in your clinic does not look sick. You ask them, are you having any problems? Oh, I have some abdominal pain, some diarrhea, I'm still going to work, so I'm not doing that great, but does not look sick. Looks okay and is easily ambulating, and most likely, not always, but most likely their CDAI will lie between 150 and 220, and that person will have mildly active disease. So generally we may need to tweak that person's medications a little bit, but overall they're doing okay. Then somebody comes in and obviously looks sick, but does not look toxic. And my definition of toxic looking is somebody who can't give you a proper history because they're not completely with it. Somebody else has to kind of help you find out what's going on. But this person visibly looks sick, has some abdominal tenderness, has been losing weight, has significant abdominal pain. That person who's able to communicate with you fully without and does not look toxic is able to come into your clinic and sit down and chat, has moderate to severe Crohn's, and probably needs urgent tweaking of therapy, may not need to be admitted. That person's CDAI, the 1 week painful test, is going to be between 220 to 450. Then somebody comes in with their family member, and you have to just carry them in, and they're in a wheelchair. You have to call the stat team, the stat nurse team, and they're coming in trying to get their vital signs. Or just by looking at them, they're just not really with it completely. They're just too sick, abdominal pain, diarrhea, dehydrated, and the family member has to kind of tell you exactly what's going on. That person is not, I usually don't see them because they end up going to urgent care or ER, or we send them there. But these people will have severe fulminant Crohn's colitis or Crohn's ileocolitis, and their CDAI will be over 450. So this is an eyeball test that you can do in clinic and quickly make a phone call to the GI. Hey, this person is okay. We'll send him home. This person needs to come and see you right away. So looking good, feeling good, saying everything is okay, remission. Looking okay, not feeling great, slight tweaking can be seen in several weeks if needed. Looking sick, but not toxic, probably urgent referral. or urgent tweaking of things. Somebody looking toxic, probably admission or a stat nurse. So we can maybe get them in and get some IV fluids going and immediately start therapy. And this is the HBI, the Harvey-Bradshaw Index. Okay, so this is, I'll just spend a few minutes on this stuff because I don't know if you guys are interested in scoping people, but there's a sister of CDAI called the SESCD. That is a painful test. It's very difficult to calculate that score, so I wouldn't want to do it. But there's another test called there's another formula or calculator called SESCD, Simplified Endoscopic Score of Crohn's. Those who scope patients will find that there's a program called Provation that they use. Provation has this built in. So we don't have to memorize it. You can just look at Provation, and when you do your note, or when you look at someone's note, this will be a part of their note. They can do this. So it looks at the distribution of ulcers, size of ulcers, how much of each segment is affected by ulcers, how much of each segment is affected by inflammation, and is there any narrowing. And this gives you an idea about how severe that person's endoscopic disease is. Because most patients with Crohn's will have ileal involvement, you can forgo all that and just do the Rutgeer score, where you can say or just read what the doctor writes, what the GI doctor writes, and if he says or she says that there's no ulcer in the ileum, that person has an I0, is in endoscopic remission. If they say there are less than 5 ulcers, otherwise everything looks okay, that person has an I1, has mildly active endoscopic disease, is I1. I2 is if you have more than 5 ulcers in the small bowel, but the intervening mucosa is normal. That person has moderate disease and may need tweaking of therapy. Then severe disease is if you have more than 5 ulcers with intervening mucosa also looking bad, that person has moderate to severe or severe disease. And then if you have narrowing, strictures, pus coming out, obstruction, and all the other stuff, that person has severe fulminant disease, may end up needing to get a resection, or we need to do something right away. All right, so this is kind of something you won't have to deal with so much, but just an idea. And I'm happy to share these slides if anybody wants to go back and look at some of this stuff for reference. Again, 1 or 2 minutes on this. Once we know what is the class, what type of Crohn's we're dealing with, how active their Crohn's is, then we need to decide what do we want to achieve in them. Do we want to put them in clinical remission, or do we want to put them in endoscopic remission? Are there clinical trials out there which tell us, well, this drug actually, or this medication actually reduces admission rates, or by doing this, we can reduce steroid use and stuff like that. The most common theme or the most common objective for most of us is usually to induce clinical response, clinical remission, endoscopic response, endoscopic remission. We're heading towards more and more endoscopic response and remission, but most of our trials have looked at clinical response and clinical remission. And then once they're in remission, you maintain remission. That's the second step. And this stuff kind of says the same thing that I talked about: reducing recurrence, minimizing bowel damage, decreasing rate of complications, reducing rate of admissions, reducing surgery, reducing risk of infection, increasing compliance, steroid sparing, improving quality of life, and decreasing mortality. Okay, and this we'll talk about, again, I won't talk about each clinical trial in detail, but I will kind of just touch on each medication that we use mainly for Crohn's, and I'll just tell you what and how it can be used. So traditionally, there were 1, 2, 3, 4, 5 types of Crohn's medication that we gave to patients. The first one was a non-targeted immune suppression. What does non-targeted immune suppression? What's the bazooka that we use for everything which we shouldn't be using on everybody? Steroids. So steroids were the mainstay of therapy in the 50s, 60s. We found out they were causing more harm than good, so we stopped using them, or we kind of now use them sparingly. So one message I want to send out for Crohn's: steroids should only be used when there's no other option. But this is something that it used to be mainstay of therapy, and now we're trying to stay away from this as much as possible. What's the other type of medication that we use for Crohn's? Antibiotics. Cipro, metronidazole, and somewhat rifaximin. These 3 antibiotics have good evidence to support their use, mainly in colonic Crohn's, but we can use them. Topical anti-inflammatories, mesalamine agents, stuff like Pentasa, Azicol, Delzicol, sulfasalazine, dipentum, stuff, balsalazide. So these medications are, we think, topical anti-inflammatories and can be used in Crohn's, but I'll tell you when, because their effect is modest at most. or have no effect. Then the fourth category is when you inhibit replication of inflammatory cells by inducing apoptosis or cell death. Which drugs do that? The thiopurine analogues. What are the thiopurine analogues? Azathioprine, Imuran, 6-mercaptopurine, or 6-MP. Then the fifth type of drug that we use traditionally and even do so now is the one that inhibits replicating inflammatory cells by inhibiting mitosis or cell division and cell spread. Which drug is that? Methotrexate. So the 5 types of traditional drugs we use for Crohn's that you'll hear about, or you should know about, are steroids, antibiotics, topical anti-inflammatories that are mesalamine type agents, methotrexate, and then thiopurine analogues such as azathioprine or 6-mercaptopurine. Just remember the names, and you'll have you'll get an idea if you ever see somebody with it, and we can talk more about it if you guys have time after this. What are the newer drugs? So the stuff in blue is kind of in flux, is being tested or has been tested, isn't working so well. I'll talk about the stuff in green. So targeting effector cytokines. Cytokines are things that come out of cells. These are the chemicals that drive inflammation. So what inhibits cytokines? What's the most famous cytokine that we inhibit when we treat Crohn's and colitis? TNF. So by inhibiting TNF, we try to kind of reduce the inflammation that's occurring in Crohn's and colitis. What's the other effector cytokine that we use we inhibit? What's the newest drug on the block? Stelara, ustekinumab, IL-12/23, P40 subunit inhibitor. So TNF and IL-12/23 are cytokines. These are chemicals that come out of cells that cause inflammation. Targeting immune cells, none of this stuff is approved yet, so we'll keep going. Inhibiting cell trafficking. The Crohn's inflammation occurs when you have inflammation that arises at the intestinal tract. So the alpha-4 beta-7 and the alpha-4 inhibitors, Natalizumab and Vedolizumab, or Entyvio, that you guys must have heard about, what it does is it inhibits the adherence of a cell coming from outside the intestinal tract to a cell that occurs in the endothelium of the intestinal wall and keeps them from getting inside. So it's kind of more local action. And that's Entyvio. And okay. So now I'm going to talk more about the stuff in yellow font. We'll talk about induction of response or remission and maintenance of response or remission. Somebody comes in with active disease, should we be using mesalamine agents? So all the clinical trials that we've seen or have done have shown the following. Mesalamine agents have no, minimal, or at most a modest role in induction of clinical remission or response. If you want to use it, it should always be used as adjunctive therapy with some other agent, and basically should be used mainly for colonic disease. So the right answer on the board is going to be, if they give you an option to use mesalamine agent for Crohn's, the answer is going to be no, because there's a modest or no effect of mesalamine agents in treating Crohn's. And we used to do it a lot because we didn't have other options, but now we think that at most it has a adjuvant or adjunctive role to be used in mild Crohn's in the colon with other therapies. So by itself, we don't use it. To maintain remission, same thing. The role of mesalamine agents to maintain remission or response in Crohn's is none, mild, or very modest. And if there is a role, the role is in colonic Crohn's, mild Crohn's, and when you use it as an additional agent to other traditional or biological drugs. What about antibiotics? Antibiotics, the most evidence that there is for Cipro, metronidazole, and rifaximin. They have a true role in inducing remission and response in mainly perianal and colonic Crohn's. So clinical trial evidence has suggested that antibiotics, mainly ciproflagyl and rifaximin, do have a role. For example, if somebody comes into your clinic and you want to bridge them till you get them to the IBD doctor, you can, colonic Crohn's, perianal Crohn's, put them on antibiotics and get them to a GI doctor, which may take a week or two. Maintenance, there's paucity of data, but there's no strong data yet to suggest that you can use antibiotics long-term to keep people with Crohn's in the colon or perianal Crohn's in remission. So the role of antibiotics is limited to induction for about 2 to 4 weeks. We kind of break the rule and do it more often, but again, the right answer in clinical practice, the right answer on the board, the right answer at a dinner is you shouldn't be using it long term. All right, steroid therapies. So yes, steroid therapies work in inducing remission and response. Again, because the side effects are so significant, we should always weigh our options. Whenever you have a choice, you should try to bridge them with antibiotics, bridge them with something else, maybe a mesalamine agent to kind of slowly kick in by the time the antibiotics kind of begin working. But yes, there are times when you'd have to do prednisone or budesonide, but again, use it sparingly as much as possible. There is a role. The right answer is going to be steroids. If they're mentioned in inducing remission in Crohn's, the answer is going to be yes, but then you'll also have a caveat, always avoid it when possible. So if you have another option, like a biologic, that's approved for induction, then that would be the right answer. Maintenance, never. So we should never use steroid therapies for maintenance of remission in Crohn's. The answer is always going to be no. Budesonide, in some cases, has been used over 9 to 12 months. But then after 6 months, you begin to see steroid side effects, so you would try to avoid that too if possible. But yes, budesonide, because it's topical and it has a strong, fast first-pass metabolism, one could use budesonide for local ileocolonic disease or ileocecal disease for 3 to 6 months. What about thiopurine analogs? So the right answer, if you are to kind of induce somebody, if somebody has active disease, thiopurine analogs don't work for 3 to 6 months. So you can't expect somebody to feel better next week or the week after if you put them on a low dose of Imuran, even a high dose of Imuran or 6-MP, because it does not work in induction. You want to bridge them. One option is to start a biologic on day 1. Another option is to bridge them with antibiotics, possible steroids till you get induced with a biologic, or if you really have a lot of time, then you can wait, because these things begin to work over 3 to 6 months. Maintenance of remission, yes. There is evidence for modestly successful use of thiopurine analogs for maintenance in Crohn's, including preventing relapse while in remission and reducing steroid use. So yes, if you have an option to maintain people in remission between steroids and azathioprine has evidence to keep them in remission and avoids the avoids steroids. So azathioprine, no role in induction, role in maintenance. Steroids, role in induction, no role in maintenance. Methotrexate, in some studies, even though methotrexate is also majorly used for maintenance of remission, but can be used based on some trials to bring about a clinical response in about 4 to 6 weeks. So if you have 4 to 6 weeks, if somebody has moderate disease but wants to kind of not get into something big and wants to kind of, is okay with waiting to get better over 4 or 8 weeks, then methotrexate may actually be a better choice. Obviously with the side effects of methotrexate also being considered. Maintenance, there's evidence to suggest that methotrexate works in Crohn's to maintain remission and avoid steroids. Cyclosporine and tacrolimus, I've used it because I have a lot of Crohn's patients and I run out of options. But clinical trial evidence is, there's not enough clinical trial evidence to suggest that you can use tacrolimus or cyclosporine. You may see people use it once in a while, but there's no strong evidence to use it. We do it based on anecdotal evidence or our own experience. So Infliximab is Remicade. So there's 5 seminal trials. CA2 luminal Crohn's induction trial, the CA2 fistulizing Crohn's trial, ACCENT-1, ACCENT-2, and SONIC. All one has to remember is that Infliximab is effective in induction of clinical response and remission in moderate to severe luminal Crohn's. Based on the CA2 fistulizing trial, it's also effective in inducing a reduction in fistula drainage and closing of fistulas during in moderate to severe fistulizing disease. So Infliximab, a TNF blocker, there's enough evidence and the greatest evidence compared to all of the biologics that it can be used in induction. So at UAB, if we get somebody admitted to the hospital and we know for sure this person has moderate to severe Crohn's, in many cases, even before they see the face of steroids, we induce them with Infliximab or Adalimumab, a TNF blocker, because it's approved for induction, and it works, and it avoids the steroid side effects. Accent 1 basically shows that it's also, the reason we also prefer this, because infliximab is also effective in maintaining remission in luminal and fistulizing Crohn's. SONIC trial basically suggested, and the right answer on the board, even in internal medicine board, if somebody has severe fulminant or moderate severe disease and they make it look like the patient is very, very sick, and they give you a choice between an induction of response or even maintenance therapy. If a patient comes in with Crohn's who's very sick, and I saw this in internal medicine board, very sick looking, they make it sound like very sick but not ready for surgery, and they have options of infliximab, methotrexate, blah, 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 and there is an infliximab with, or a TNF blocker with a traditional immune modulator, like infliximab with Imuran or adalimumab with methotrexate. The right answer is going to be dual therapy. So for very sick Crohn's patients, dual therapy with a TNF blocker and a traditional immune modulator is the right answer, because the response rates are about 10 or 20% higher if you combine the two. Adalimumab, almost exactly the same thing as infliximab. Adalimumab is Humira. So again, it shows the same thing, that Humira works as well in clinical practice, in clinical trials, as infliximab does. Then we have a sister of Humira and Remicade called Cimzia that you hear about. Cimzia was not able to achieve clinical remission, but was able to achieve clinical response at 6 to 10 weeks. Of those people or patients who responded to Cimzia at week 6 to week 10, they are the most likely to actually be in remission at about 6 months to 1 year. So the reason you see more Humira prescriptions out there, more Remicade prescriptions out there, and less Cimzia prescriptions, because of this clinical trial. Because while Humira and Remicade worked to induce clinical remission, Cimzia failed in its clinical trial. But those who respond in the beginning, at week 6, those patients can actually stay on Cimzia and are more likely to be in remission at 6 months to 1 year. I don't use Natalizumab because of the risk of PML, and now because we have Entyvio as well. Vedolizumab is a Gemini-II trial showed that vedolizumab, which is the alpha-4 beta-7 inhibitor, which keeps the cells from adhering at the intestinal wall, is more localized. It also can be used for induction and for maintenance of remission and response in Crohn's. The rates were slightly lower than the traditional TNF blockers, but we've seen that if you use this in TNF-naive patients, even though it takes a little longer to work, vedolizumab or Entyvio is an absolute valid first-line therapy when you can't use a TNF blocker and you're able to wait longer to use in Crohn's patients. The newest drug on the block is ustekinumab or Stelara. Unity-1, Unity-II immunity, just to kind of save everybody's time, basically what it shows is almost as good as TNF blockers when used among TNF-naive patients. So Stelara is a second or third line agent among those who've already been on other TNF blockers, but if you use this in TNF-naive, those patients who've not been on Humira, Remicade, or Cimzia, then the response rates to Stelara in Crohn's patients for induction and maintenance are as good as those who receive TNF blockers as first line. That's the moral of the story. And this stuff that I talked about earlier, try to keep them from getting complications of the disease. We have how many more minutes? 10 more minutes. Who's ready for questions? Who was listening? All right, this is going to be easy, and I think I kind of threw out some clues in the middle of the talk. Okay, here you go. So 43-year-old white male with small bowel obstruction at age 25, followed by ileal resection of that region, ileum, and a diagnosis of Crohn's at that time with no treatment afterwards. He did well for many years and now comes with symptoms of recurrent obstruction. What type of Crohn's does he most likely have in terms of classification? What is the anatomy of his disease? Early adult onset stricturing Crohn's ileitis, middle onset, is there such a thing as middle onset? Early adult onset penetrating Crohn's ileocolitis. So does he have stricturing disease? Does he have ileitis? Does he have penetrating disease? Does he have ileocolitis? Is he early adult onset? Is he middle onset? So early adult onset stricturing Crohn's ileitis. That's pretty simple, right? Everybody got that? Because he got Crohn's after, he's not pediatric onset, he got Crohn's around 25. He had ileal small bowel obstruction, not affecting the colon, and then had an obstruction, so stricturing, and then came back many years later with the same thing. All right, good job, guys. What about this one? This is now we're going to talk about the physiology of the disease activity, and I want you guys to use the eyeball test. Well, you're not looking at this guy right now, but just imagine him over here, and then see what you think. 23-year-old African-American woman, or this lady, 23-year-old African-American woman presents to clinic reporting 6 loose bowel movements a day with moderate lower abdominal pain and feeling very poorly. No EIMs, no extra-intestinal manifestations. She looks visibly ill, but not toxic, and is able to ambulate. What is the most likely category of disease activity if you had 1 week to calculate the CDAI, or if you had a MedCalc to calculate HBI? Visibly ill, not toxic. Says she's sick. Is it mild to moderate disease, moderate to severe disease, or is it severe fulminant disease? Moderate to severe disease, perfect. Thank you, guys. You guys were listening. Okay, this one is going to be a little tricky, but if you get this one, I think you guys were all completely awake throughout the talk. So 42-year-old white male presents with moderately to severely active early adult onset penetrating Crohn's ileocolitis. And these are all fancy words. It's not really that fancy. This is all pretty simple. I'm using fancy words to kind of confuse everybody, but this is very simple stuff. Moderately to severely active early adult onset, penetrating Crohn's ileocolitis with perianal and antroduodenal disease, as well as peripheral bilateral inflammatory arthralgias, peripheral type 2 arthritis. What is the best management option for induction and maintenance of response? 1, prednisone plus antibiotics plus mesalamine agent. 2, TNF blocker plus methotrexate sub-Q with folic acid plus PPI. 3, ustekinumab plus Thiopurine plus PPI. 4, Vedolizumab plus azathioprine plus PPI. Natalizumab is option 5 with PO methotrexate with folic acid. Now remember the 2 clues here. This person has antroduodenal disease, so should be getting something for that. And this patient has peripheral type 2 arthropathy, so should be getting something in addition to the best drug class we have out there. So what is it? 2? Exactly. Wow. You guys got it. Fantastic. Okay, exactly right. TNF blockers are the main agent that we use, which have the most clinical evidence behind them, clinical trial evidence to suggest that they work for moderate to severe Crohn's of all types. We know that 2 drugs are better than 1 in somebody who's very sick, especially if they have type 2 peripheral arthropathy. What works the best? Methotrexate. If somebody also has antroduodenal disease, then you add a PPI. One could also add antibiotics, but if you get them on a TNF blocker right away, you may not need to bridge them with antibiotics because you can induce response right away with the TNF blocker. This is it, and I have to go back and do clinic now. I wish I could stay here. But if any questions, concerns, edits, corrections, feel free.